Okay, we're live now. So hello everybody, welcome to the next session of the International Virtual Dental Conference. With us we have a respected speaker, Professor Dr. Adnan Ali Shah. Professor Dr. Adnan Ali Shah is the Diplomate of the American Board of Maxillofacial Surgery. He is also the Professor, Chair and the Program Director of Oral and Maxillofacial Surgery at University of Manitoba, Canada. Dr. Adnan will be talking about the innovations of dentistry during the COVID-19 pandemic. He will cover oral surgery post-COVID-19, the latest tools to help dentistry grow in Pakistan, telemedicine, digital dentistry, innovation in dental equipment, and improved PPEs. Thank you so much to Dr. Adnan Ali Shah for joining today's session. I'll hand over the session to you, Dr. Adnan.
Thank you very much for introducing me to the audience. Assalamu alaikum, good morning, good afternoon, good evening. It's good morning here in Canada. Let me take this opportunity to congratulate the organizers of first virtual dental conference being held in Pakistan. It was a terrific idea by Dr. Akib Mudassir and his co-workers. And I think probably provided us the best platform to brainstorm our ideas and thought processes and find solutions and answers to the challenges that we faced. I would be talking today about the practices in oral surgery as it impacted due to the COVID-19 that we're all facing, and we continue to face this pandemic as we talk. This is Winnipeg, where I come from. It's a city in Western Canada in the province of Manitoba, a small city of about 700,000 people, and a total province population is about 1.3 million. We have got two rivers, which is close to what I see in Lahore, one river and one canal flowing through it. This is the aerial view of Winnipeg in summer. This is a slide, current slide from Johns Hopkins COVID-19 Resource Center. And as we see, there are over 20 million, or close to 20 million people infected with this coronavirus. And the global death toll is over 700,000. So this remains the most devastating pandemic the mankind has ever known after the Spanish flu. In fact, the damage inflicted through COVID-19 probably is way more than what people would have expected or have endured through the Spanish flu time. Looking at Canadian status, we have about over 120,000 people inflicted with this virus. We've recovered about 105,000, and there are about 9,000 deaths in Canada so far. But when we compare Pakistan has not done bad, to be honest. We've got about 282,000 people that have got coronavirus. It may be underreported, but still, the figures are fairly encouraging when we look at the rest of the world, and especially the Western world. Recovered category amounts to about over 250,000 patients, and we've got about 6,000 deaths. And it's interesting whether it was the hot weather, the humid weather, the herd immunity, or something else. We still need to discover that. When we talk about Manitoba, the province I come from, the political leadership, the healthcare leadership, and the people together have done a tremendous job. We have, as of today, only 132 active cases, although these cases were brought down to almost zero at one point, and we'll talk about that in a short while. But there has been a gradual resurgence of COVID-19 positive patients in the province now. We have only 8 deaths so far, and about 9 current hospitalizations with 3 individuals in intensive care. This is just a graph to show that we had a huge surge of this pandemic in late March and April, which came down to almost zero around late June, but there's a resurgence back again starting from July. And then in August, we did see the highest number of people that were reported positive was yesterday, about 30, which did alarm the healthcare providers and the political leadership in this province. It's interesting to know that classically it was the elderly, but now the research and the statistics actually show that it's most people who are getting this virus in our provinces aged between 20 and 40, and this explains the lifestyle and ignoring the protocols outlined by the health authorities and the government in the province. It's probably now more in the younger age group people, and I think the elderly are probably spared because more protective measures have been taken in that respect. And if you see this curve, we had more recoveries and we already came down to 0, but there's a resurgence again. And the infectivity in the and the Manitoba 5-day test positivity rate were almost 0 in early July, but we've gone back to again. Today it's about 1%. We're still below the community spread of 3%. So hopefully, if we get back to our contact tracing, isolation, and aggressive testing of our community, we should be able to control this better. Why do we need all this? Is because we see from this graph that if you do not have protective measures, then the spike would go up and you will not be able to flatten the curve. And as such, there'll be overburdening your healthcare system, which will not be able to cope with the number of patients to cater. So we need to take all those protective measures to flatten the curve and start the recovery phase that we all hope for. But as of today, in most parts of the world, there is resurgence. Then in some parts of the world, there are still ever-growing numbers of infected COVID-19 patients. This all started with this communication from Stanford School of Medicine, communication in early March, where Dr. Tong in neurosurgery in hospitals in Wuhan informed that there was a widespread involvement of healthcare providers inflicted with COVID-19, and all 14 patients, one of their ORs, doing an endoscopic case on a pituitary tumor, were all inflicted with this disease. And then it was noted that the doctors who died in China were ENT and ophthalmologists, possibly due to high viral shedding from the nasal cavity. This triggered further concern, and as such, if I still remember, based on this information that we received, our medical director called me that morning, and we stopped our big ZMC, zygomaticomaxillary complex fracture, that was going to be operated that morning because of the scare of possible transmission of this virus to the professionals and the healthcare providers within the OR, and patients who were and then people who were actually operating upon these patients. And we had to cancel that patient for the next 14 days, although that patient was inpatient, and repeated COVID testing of that patient had to be undertaken before we could take him back after 14 days to operate that patient. And this further communication of the viability of this virus in aerosols throughout the duration of aerosolization, and that can remain suspended in the air for about 3 hours, further had serious concerns for the healthcare providers and their safety. And this article also provided some information that how long this virus could survive, and you can see in the aerosols it could live up to 3 hours, and on different materials like copper, cardboard, plastic, and stainless steel, anywhere from 4 hours to about 72 hours. And that was more important for OR settings, for hospital settings, and for dental operatories. These two papers were probably the baseline papers which actually introduced the emerging challenges for dental and oral medicine people, and they highlighted the routes of transmission in controlled dental practice environments. And we now know the virology and transmission modes of these. This is a novel coronavirus, SARS-CoV-2, and we also know that the incubation period varies from 5 to 6 days and go up to 14 days. Symptoms may appear up to 14 days plus. Chinese report up to 26 days. Transmission is respiratory droplets, contact transmission, aerosols, and some vertical transmission, which is fairly unknown at this point. Mother to the newborn, there have been some cases reported to have that happening. So we know from these two papers that how an infected patient through droplets can have airborne and cause this disease in susceptible individuals. You could have droplets, aerosols produced in a dental practice. It could have contaminated surfaces while sitting on dental chairs in the waiting areas, coming in contact with the front desk people. So the communication could be direct to dental professionals or indirect contact as well. This necessitated that what needs to be done, what would be a dental emergency in these situations to be treated. And this was an ADA handout, and I've downloaded from there. And it constituted what dental emergencies were that were potentially life-threatening and requiring immediate treatment. What were urgent dental care, which could be managed at an appropriate time, and what could be other dental care, and what were non-urgent dental care procedures that could be avoided. The dental surgery and oral surgery emergencies basically revolved around acute pain that cannot be managed pharmacologically. We'll talk about that later, that what were the effects where we went pharmacological, and we saw some of the severest infections, and we'll talk about that later. Orofacial trauma potentially compromising airway and vision injuries, prolonged bleeding, soft tissue, facial neck and space infections, both intra and extraoral, causing trismus, difficulty in swallowing, and potential airway compromise. And if you remember, we were frontline workers in our hospital, and we continued to provide treatment to these patients on a regular basis. There was a lot of unpredictability that what's going to happen. We didn't have answers as we have today. So things were very fluid and very scary at that time. The urgent dental care could be rounded around pericoronitis or around the third molar, causing pain, especially in pregnant second trimester patients. That could be also a consideration. Surgical postoperative osteitis, which is known as dry socket, localized abscess resulting in localized swellings and pain. You could have tooth fracture resulting in pain and soft tissue irritation, dental trauma with avulsion and luxations, and extractions required prior to some medical treatment that would require cancer treatment in terms of radiation therapy and chemotherapy for these patients. So patients who were undergoing surgical resections and ablative and reconstructive surgery. Biopsy of suspicious looking lesions, both soft and hard tissue, and lacerations that were reported to the ER. We then went into a red alert phase, and in our province, that was around March, April, and May. We have moved further than that now. We've reduced the red alert phase is all over, and we've moved into the third phase where we have completely reopened our clinics. But it all depends on the areas that you come from. It depends on the burden of disease in that specific area. And I'm sure there are, and I'm positive, and I know that there are areas in the world, and there are countries in the world which are still going through the red alert phase. And we don't know when it will come back again, because as we see resurgence here in my city, in my province, there is always a concern that we may go back to this red alert phase starting this fall. And I'm sure in the context of Pakistan, we probably are still in the red alert phase. So what needs to be done in that phase is that you stop routine and non-essential oral surgery or dental surgery care of the patients, apply stringent patient screening protocols. We'll talk about that in a minute. Triage patients and deliver advice pharmacological wherever possible remotely about telemedicine. We'll also talk a little bit about telemedicine. What are the pitfalls? What are the pearls of telemedicine? Refer presumed suspected or confirmed COVID patients to designated emergency facilities. And this is very important when we need to develop those facilities in our surroundings so that these patients can be transferred and can be referred to appropriate centers where all the protective measures are taken and they are provided standard of care. Use of recommended personal protective equipment, again, extremely important, with enhanced droplet and contact precautions to apply decontamination processes. Minimize COVID spread by eliminating aerosol generating procedures as much as you can. And I think this probably has changed from now in our setup here in Canada, where our operatories, our hospitals, our clinics are fairly equipped to deal with aerosol generating procedures. Taking all the precautions, we've embarked on a full-scale return to normal practices in all the healthcare areas. And this is possible if we have all that available for us to do. Just to remind, the management of COVID-19 is a fluid situation. It is a fluid situation due to fluid nature of the COVID-19 pandemic. These protocols that we talked today are being reviewed and updated, including this one. So it may be true what we talked today, and it may not be adequate for tomorrow. So whatever we are talking today is based on whatever knowledge we have until this point, and things could change, and it continues to evolve. And I remember in the earlier days, we were having our review protocols published and dictated to us probably on a daily basis. For pharmacological therapy, I wanted to run this down by all of you because it'll be interesting to know that we could actually use quite a few tools available to us in terms of our medications. For pain management, you have Tylenols, which is probably the first line, plus minus added with NSAIDs like ibuprofen, naproxen. You could add first line opioids like codeine and tramadol to it. The second line could be oxycodone, and third line would be hydromorphone. Now, remember, you need to have triplicates to have opioids prescribed in Canada. We like oxycodone, hydromorphone, and it would not be possible for these patients to have it taken over the counter. In terms of pulpitis and pulponecrosis, consider adding corticosteroids. Dexamethasone of 8 milligrams once daily for 3 days would be helpful. In patients who have gastric problems, they could have omeprazole to actually counteract the effects of those medications on their stomach. Antibiotic first line, as we all know, is penicillin, amoxicillin, followed by Clinda. And you can always use erythromycin. You can use cephalosporins. And your third line perhaps would be moxifloxacillin, which is 400 milligrams PO once daily. And I thought this would be nice for our viewers to review. In the pediatric population, it remains the same, but certainly the dosage would come down based on their weight. What was more important, and it still remains very, very important, is the stringent screening patient protocol. And we have adhered to that in letter and spirit in our hospitals. I've been screened every day. My temperature has been recorded every day. I've been asked these questions frequently. I walk into my private practice. My front desk receptionist actually screens me every day in front of my patients. And it's important that the patients know, and we'll talk that in our last slide, that how important it is that what you do, what you talk, what you tell them, and how do you perform all those steps so that you ensure confidence and perform smooth functioning of your operations in your healthcare setting. We know that fever comprises 98.6% in these patients, followed by dry cough, headaches, fatigue, aches, and pains in about 34%. But also, it has been reported the loss of taste in about 40% of COVID positive patients who were still asymptomatic. What is important is that we need to reinforce that there have been that all returning travelers, those who have traveled within or outside the country, should self-monitor and self-isolate for 14 days, because 99% of them develop symptoms within the 14 days that we have. It is important to ask, have you been in a large setting in the last 14 days where someone has been confirmed or suspected COVID? Have you had contact with someone face to face for less than 2 meters, 6 feet with respiratory symptoms or illness? Have you been tested for COVID-19, presumptive or confirmed? And we know from the timelines that we have time from first symptoms to dyspnea onset is about 5 days, to hospital admissions about 7 days, and to develop acute respiratory distress syndrome is about 8 days. About 16% of them would actually go. And if you do have any of the above, then you probably need to seek advice from the designated healthcare providers. Other question that you may ask is, do you or a person you're inquiring about have the following symptoms? And this is all done on the phone before we entertain these patients in clinics. And this has been reinforced back when they walk into your office or in your healthcare setting, that these questions have to be asked again. Severe difficulty in breathing, chest pains, confusion, extreme drowsiness, and loss of consciousness. If this happens, then obviously they needs to be referred to an emergency department in the hospital setting. We know for sure that mild, which is about 80% of these cases, would have no fatality, and also the severe case, which amounts to 14%. But 5%, which will go to critical stage, would have about 49% fatality. And this is confounded by various other factors like cardiovascular disease, diabetes mellitus, chronic respiratory disorders, hypertension, cancer patients, and patients over 70 years of age. Risk assessment form that we apply at our center, at our hospital, in our emergency setup, and also for normal treatment now is simple. Did you have fever, or new onset of any exacerbation of chronic cough, sore throat, shortness of breath? This is a standard questionnaire that we all know about. Running nose, loss of taste, loss of smell, and all this. And then this is asked on the phone before an appointment is booked, and this is followed by similar questions back again when they arrive at the healthcare facility. And this has been then signed by the staff screening that patient, and the patient actually signs for medical legal reasons. So the patient has given you the right information, and the staff has certified that information. We developed an algorithm for our workplace with high-risk procedures for low-risk patients, and obviously there's been triage by the dentist referral, and this triage either in those days would go to oral surgeon or to the endodontic or to the endodontist for the endodontic therapy or whatever needs to be done. Now, the decision that you had to make is whether this is an emergency or the patient can wait for 14 days, or it could be managed pharmacologically and then go in for self-isolation. Patients who are asymptomatic could then go to isolated dental surgeries, which were equipped with all the necessary equipment as PPEs, and the facility that's been upgraded to handle COVID-19 patients. Patient treatment that would be considered as aerosol-generating medical procedures would need viral testing 48 hours prior to their treatment. And this was mandatory until we moved into a third phase of reopening completely, where probably triaging and risk assessment based on a questionnaire and physical testing of their temperature is appropriate. Patients who were symptomatic were straightway ordered viral testing, and if they turn out positive, they were either their treatment was delayed till they become asymptomatic, or it was an emergent situation. They were referred to hospitals where enhanced droplet and contact precautions were taken in an appropriate OR setting. High-risk procedures with high-risk patients were obviously again triaged the same way, but most of them were actually treated in the hospital setting rather than a private setting. But if they have been self-isolated, the viral testing with symptomatic and repeat on day 12 is asymptomatic, then they were treated in isolated operatories, dental operatories. But if they were symptomatic, then there was a reconsideration of dental treatment until asymptomatic or was sent to a hospital setting to be treated. What was again very important, I couldn't emphasize more on it, is the personal protection equipment. And there has been lots of it going on, but nothing could be said in terms of nothing more could be said in terms of how important this personal protection equipment has been. And it's important that we acquire and follow the steps that we have. So what we went through, and I probably have gone beyond that, I probably have everybody as a potentially high-risk patient for me. And I would actually try and follow whatever is recommended by our health authority. So for non-aerosolizing treatments, you have buffon caps, head caps, use of double gloves and STM level 3 masks, N95 or half-face respirators, eye protection, tight seal goggles, and medical gowns, impervious to fluid resistant. Use of double gloves for aerosol producing treatments, use of buffon caps, and then again level 3 masks, N95 house mask respirators, eye protection, surgical impervious resistant gowns, and shoe gloves. Patients who would have AGP will all undergo viral testing 48 hours before the procedure in the OR, and we still practice that in our hospital setting. Another important area is donning and doffing of the PPPs. And from the previous SARS episodes that we had in the early 2000s, there were reported cases of contamination and infliction of virus to healthcare providers because they were not properly donning and, more importantly, doffing of their PPPs. I won't go into the details. It's all down and everybody knows it very clearly, but it's very important that we perform hand hygiene, we put on our mask the right way that we are told, and we take off each one of these items as outlined in the protocols with proper hand hygiene. What considerations would you have providing treatment for a situation like the one that we are in now? After proper screening is maintaining a strong triage by telephone or other means. Early evidence suggests that use of 5 cc's of 1% of hydrogen peroxide rinses 30 seconds to 1 minute or 0.2% povidone may help reduce the viral load. But it remains to be seen for how long, because your submandibular gland does provide resting saliva, and then the virus rests in the salivary glands. So we do not know how long this perhaps rinse would prevent or neutralize the virus within the oral cavity. Use of OPGs or Panorex X-rays, high-speed suctions intraorally to minimize aerosols or avoid them altogether. Avoid invasive techniques where possible. Consider alternating operatory use to allow fallow time between patients to properly disinfect. And as a general rule, it should be 3 hours if you have normal air changes per hour. Because that was the time that was suggested by various studies that the coronavirus remains suspended as droplet, as aerosol within the operatory. Have proper ventilation. I think it's important that we have dilutional ventilation. You can bring in fresh air into the operatory, preferably with an air scrubber with minimum of 15 to 16 air changes per hour. And if you have that in your operators, you could probably bring the follow times about 30 minutes between the two procedures, which is fairly achievable. And you need some changes within your healthcare facility, and it's easily doable. Disinfect with 70% alcohol disinfectants in the operatory with standard precautions for cleaning and disinfection. Maintain physical distancing. I would not underscore anymore. This is the most important factor in actually minimizing the contact transmission. Maintain hand sanitation. Limit the access to treatment area only to bare minimum personnel with appropriate PPEs. Extremely important there. This is some of the pictures that we had in the initial days with negative pressure operating rooms of COVID-19 patients, and the one on the right side was a high-risk patient with unknown status, and we were using complete pepper, and you could see me wearing all that. It was an IND of a deep neck and space infection that we had to undertake in the initial days. And since it was an emergency, so there was no COVID testing, and the patient remained in a higher risk category because of the habits and because of the environment that he was living in. This is another picture of my private practice setting, wearing both half mask and half mask respirators with face shields, Buffon caps, me and my assistant, and very minimum solid structures placed within the clinic. Everything is outside. The doors are sealed, and we have negative pressure with air scrubbers available in our surgery. And we give about 30 minutes between patients before we can re-enter the surgery again and perform another procedure on other patients. Telemedicine has been talked, teledentistry has been taught a lot, and there have been a lot of talk about face-to-face versus remote consultation. And this is a great paper that came up recently. I think it's still in publication, where in the UK they evaluated the remote OMFS assessment in the era of pandemic and taking control measures. So it did start the process of virtual clinics. We were doing virtual planning on our orthokinetic surgery cases and virtual planning for other surgical procedures, but it did brought about a concept of virtual clinics, which was certainly very cost effective. It did reduce the wait times for patients regarding consultations. And there was an overwhelming response by the patient community. About 59% expressed strong preference for teleconsultation. Only 13% had a strong preference for face-to-face consultations. But there were certain reservations from the clinician standpoint. And the first of all was the diagnostic uncertainty. They still needed to have hands-on examination of these patients. There were concerns of missed malignancies, and I can totally understand that. There were problems, hearing problems, poor quality calls sometimes. There were language barriers. There was difficulty in treating some of triaging on the phones or on the video calls when it came to children. And people thought, the clinicians thought, there was a poor rapport and there was no element of reassurance that we see it in face-to-face domain. And they were unable, obviously, to provide complete perioperative tasks via the phone, except for pharmacological therapy that was needed. And that had its own downside. We'll talk about that in a minute. And more importantly, a visit to the hospital still required in most situations, with more serious and grave situations later on. So the recommendations then came up with the high-risk patients like head and neck cancer still require face-to-face. Children and those with difficulties and language barriers need face-to-face consultation. Low-risk benign conditions or remote consultations can be preferred. Clinicians, patients can't, and there were always a recommendation that as we move forward with this new concept of virtual clinics, And as the clinicians and patient develop confidence, which was likely to increase in proportion with increased familiarity with this concept and with this thought, brought about by the healthcare changes and certainly mandated by COVID-19 pandemic, we will be looking at more people referring back to virtual clinics, and I think that will be a thing to go forward with, with with caution initially, and obviously once we would be in a situation, we'll be coming up with some protocols, and we will be able to define parameters that what type of patients could be sorted out through a virtual clinic, or at least minimize their visits by initially having some virtual clinic visits on the telemedicine, teledentistry route, followed by some face-to-face consultations. At least we would minimize those interactions and those visits that we do it as of now. And this was one of my cases where he was with the Royal Canadian Mounted Police officer who had a swelling on the left angle of the mandible, as you can see here on the panorax, just below the inferior canal. By the look of it, looked very circumscribed. We did order a CT scan, which we obtained based on the CT scan radiological report, the location, our clinical judgment and knowledge. We did triage this patient and screen this patient through a telephone call, and then we had a video conferencing too. We explained the nature of this possible disease and multiple, and went through the differential diagnosis. We did a virtual consult and we did a virtual consent going in forward with an incisional biopsy, both intra or extraoral. We talked about everything on that. So it just minimized the contact with this patient. Patient was brought in 48 hours before into the city, had COVID testing, went into the operating room and was tested negative for that. We did the incisional biopsy. And the patient was shifted back to his hometown, which was about 4 hours from where we are in Winnipeg, based on the histology, which turned out to be a fibrous osseous lesion, which we thought initially it was. A consultation was again made, and a decision was made to carry out more definitive treatment. And again, all that consultation and consent forms were discussed, and through telemedicine for the next steps, and the patient will be now brought in for an OR for a definitive treatment decision. So this is something that can happen for more benign cases, and this will probably can be extended more as we develop more confidence and we get familiar with the process itself. The impact of COVID-19 on OMFS patients. There has been a tremendous impact in terms of how we manage these patients. We had to improvise our treatment protocols, and in particular dealing with trauma cases. And also, this is a great study which actually highlighted the dental infections before and during the COVID-19 outbreak, again coming out from Britain. It's about to be published in the Journal of Oral and Maxillofacial Surgery, British Journal, Oral and Maxillofacial. And it just highlights, and if you can see the graphs here, although there were more infections being reported before the COVID, but less than 30% or around 30% would have admissions to the hospital, whereas there were less number of patients reporting for any condition, and may it be maxillofacial, may it be dental, may it be ENT, may it be any other specialty. But the severity of those infections, the dental infections, were almost 80% who needed admissions. And I think this highlights the importance of urgent dental centers operating in local areas in order to treat dental infections before they progress uh, to a stage where hospital admission is required. And these patients required more intensive in surgical intervention. They were difficult to intubate. All of them were having trismus, and there was awake intubation through fiber optic means. They had longer stay in the hospital, and we'll discuss. And not only the infection, but they had some other problems involving the bone, like osteomyelitis. And long-term antibiotics and pain medication were prescribed. So they did bring in a lot of burden to the healthcare service in terms of space, in terms of availability, equipment, medication cost, and also emotional and social distress to these patients. This was another patient that we had. We were just briefly telling, had trismus, had an extraction of tooth number 48 a month ago, and she developed a trismus because of temporal space infection. She had to be awake intubated through fiber optic. We did the IND, both extra and intraoral, but I think most importantly, you see in the CT scans, she did develop osteomyelitis. So this was one of the consequences of delayed treatment because of COVID. And I think this it was important finding that we have been seeing in a few more patients in our patient pool. Now, this patient has required a CVP line. This patient would be on IV antibiotics for the next 6 weeks, and then followed by oral antibiotics for the next 5 to 6 months. So this was something that we have been facing with the COVID pandemic and with delayed intervention in these patients. And I'm told patients who would have been treated with simple fillings have gone to have developed pulpitis and root canal treatments and some paper. This is another case with huge submandibular space infection involving, and then we had to go and do an IND and removal of that tooth. What are the future challenges for oral surgery and also for dentistry at the same time? We probably are on the same boat. It's the challenge of asymptomatic, repositive, and mutant viruses that would be floating around. Upgrading the standards of cross-infection controls, stringent patient screening protocols, which we will have to continue. And I think turning this into an opportunity that we should be a part of our daily routines now. Appropriate PPEs for all the staff, and to the physicians and clinicians themselves, redesigning of operatories, surgical treatment algorithms reviewed and updated, most important, negative pressure operating rooms where air scrubbers are used, and rapid and reliable viral testing kits available to now. This will probably be the turnaround thing, which will probably make our decisions more safe and appropriate while treating our patients, especially in areas where there's a high burden of disease, and development of an effective vaccine that would be an ideal situation. Now, as regards vaccine, there are some encouraging results coming from phase 1 and 2 vaccine trials. The Jenner Institute at Oxford and CanSino Biologics at Wuhan have come up with their results for the first phase 1 and 2, where they have found neutralizing antibodies were generated in 90% of participants, and responses sustained up to 56 days. Now, this has certainly triggered an argument that this could lead us to phase 3 trials, which will be on a wider scale, and subsequently there'll be a phase 4 rollout, which will be available to the general public. And obviously, people would be the health authorities will be prioritizing who would be receiving these vaccines first, and how many. General approach to COVID-19 is to control the source of infection, use infection prevention control measures to lower the risk of transmission. Very critical and very important, and more so in our dental setups. Early diagnosis, symptoms and rapid viral testing, isolation, supportive care for patients who suffer from this disease. Getting back to patient care, it's very important to have infection control plan along with environment infection control. Communication remains the most important corner and has a corner place in the overall game plan. You have to communicate, you have to plan, and you have to train your staff. Communication, because there's a lot of unpredictability. You have to tell, you have to show, you have to do, communicate with your patient staff the steps that you have taken to mitigate the steps of this pandemic. And the one that I just expressed, and when I walk into my private practice or to my hospital setting, the front desk people would ask me questions and they will check my temperature in front of one or two patients who are maintaining social distancing are present there. So it has to be demonstrated what you're doing. Dental fear or COVID anxiety is another thing that needs to be looked in. Before the COVID pandemic, 1 out of 5 had a dental fear, but after COVID, 1 out of 5 is comfortable with having a dental treatment. So that needs to be looked in, and I think we need to find ways to avoid that anxiety. Preventing dental visits is important. This has been a lot of burden on these patients. It has been compromising long-term oral health. They've been increasing pain and suffering, and I think at a cost which is financial and social too. You have to have a facility action plan which has to be reviewed every now and then on definite intervals. There has to be a clinical action plan which has to be discussed by your staff, which is very important. And then on top of that, reevaluation of plans with defined frequency. You have to revisit, keep reviewing your protocols, your facility action plans, your clinical action plans. Keep communicating with your patients, keep communicating with your staff. Everybody should be on the same page before we embark on any treatment protocol, any changes made to the game plan. I know there are difficulties, there are challenges. But these challenges could be converted into opportunities. There's hope, there is synergy, and I have no doubt in my mind that we will not be able to overcome that. Thank you very much for your patience.
Thank you so much, Dr. Adnan. It was great having you on board, and it was indeed a very, very informative session. Thank you so much.
Thank you.